everybody. We like just a little bit finishing up pharmacology, so we're going to get that finished up. We're going to talk about analgesics. Analgesics are medications, and I'm sorry I'm one too far. Analgesics are medications that stimulate the opioid receptors in the brain to help relieve pain. Not all analgesics are opiates. Ibuprofen, Tylenol, tramadol, those are non-opioid analgesics, but work on those receptors in the brain. Some of the things, though, if they are an opiate that can happen and that we see far too often in healthcare is the profound sedation and respiratory depression issues. When someone takes too much of their hydrocodone, they take too much of their, they put on 2 fentanyl patches instead of 1. They take their Roxanol if they have that for breakthrough pain. Those are different kinds of opioid medication. Tylenol number 3, which is Tylenol with codeine, or they take the Phenergan with codeine cough syrup and drink too much of that. It can cause not only one of the side effects of an opiate is sleep, or sedation, but it also can cause it will slow down the respiratory rate to the point that you can stop breathing. So there's medications that we administer to counteract that when we catch that soon enough, and that's a medication called Narcan. Narcan is often now housed in with an AED or definitely in your crash cart in a clinic, so that you could give Narcan if someone were to take too much of any of those kind of opiates while they were in the clinic or right before they came in. So just remember that analgesics that are made from an opiate, or they act on the brain like an opiate, like tramadol. Tramadol can act on the brain. Way back in the beginning of this, we talked about how it fits into receptor sites. Well, tramadol fits into the opioid receptor sites in the brain just like a regular type of opiate, something that like morphine or fentanyl or hydrocodone. Tramadol acts on the brain just like it was an opiate, although it's not even a synthetic. So some of the things that we've talked about, morphine. Another side effect of morphine that we see in about 20 to 30% of patients is nausea and vomiting with morphine. So sometimes we have to give them Zofran, which is an antiemetic, or we have to give them Phenergan, which is also an antiemetic, or Reglan. We have to give them one of those kind of medications along with it. Most opiates can do that. Fentanyl can cause nausea and histamine release. So histamine release is what happens when we have an allergic reaction. So they can feel tightness in their chest. They can have some shortness of breath. They can have clammy skin. Those kind of things can happen as an adverse reaction to fentanyl. Opiate agonist, so that's naloxone or Narcan. It reverses the effect. It doesn't last real long, and lots of times we have to give it more than once. But trust me, if someone has had an opiate overdose, when you give them Narcan or Noxolone, as soon as you're through administering that, they are awake and alert, and it works that fast. It works very, very quickly. Narcan is most often given IV, but they do have some Narcan nasal spray in trials, and it may be being released this year. I have to look back on that and tell you for sure. But we definitely administer Narcan or naloxone if we feel like someone has had an opiate overdose. Other things that are opiate antagonists would be Dilantin or phenytoin, and Cerbex. Cerbex, both of those medications, phenytoin and Cerbex, are used to treat seizure activity. They have you can give those for people who have seizure activity. We can give those medications, Dilantin and Cerbex. We can give them for over a long period of time. We can give them IV. Dilantin can be given PO. Cerbex is only an IV med. But sometimes we will start someone who's having, once we have taken that opioid response out, sometimes we have to give them Dilantin or Cerbex because it will cause seizure activity when we pull them, inhibit those receptors in the brain so quickly, we'll need to give them something because it will cause seizure activity, especially if someone is overdosed and they're a long-term user and we mess up those receptor sites in the brain, then we need to give them something. We give Cerbex most often in the ER, Dilantin at home more often. And the reason why we give Cerbex most often in the ER or in an emergency situation related to seizure activity from opiate overdose is because there's not a lot of adverse effects with Cerbex. Dilantin does, and you have to have a therapeutic level of Dilantin. So we give that and we get them started. We get their seizure activity under control. Then we switch them over to a pill Dilantin. Medications affecting the GI system. So we have histamine 2 blockers. So sometimes if someone goes in or someone is having an allergic reaction and they've used their EpiPen and we've given them we gave them in a clinic, we gave them a antibiotic shot, and before they leave they have an allergic reaction. Well, we're going to go ahead and give them Benadryl in a clinic setting. We're going to give them epinephrine we're going to give them epinephrine IM. And then we're going to pull something like one of these histamine 2 blockers, Zantac, Tagamet, or Pepcid, and we're going to go ahead and give that to them too. That way we block histamine 1 and histamine 2 receptors and more rapidly and for a longer period of time can slow down that allergic reaction. So they're also used to treat things like stomach ulcers, reflux, and other stomach issues, but we also use it as part of an allergic reaction treatment. Antiemetics, I talked to you about those a while ago. Phenergan or promethazine, it can be given by mouth, it can be given rectally, or it can be given IM or IV. Compazine is one that we don't see used as much. We use Zofran in place of that more often, but Compazine also works, especially when the Phenergan and Zofran don't work. We will go to Compazine. Compazine can be given PO or IV only. An antiemetic prevents vomiting. Now, Reglan or metoclopramide, it increases GI motility. So what happens is it's given orally or IV or IM, and it actually speeds up or increases the movement of the GI system. And so what happens is someone who has been nauseated, we can go ahead and give them Reglan, and it can get that food that's in the stomach or acid that's built up in the stomach. We can go ahead and get that into the intestine so it can decrease vomiting. Also, some people that have other issues, they have dumping syndrome or they have some other stomach issues, we can give Reglan also to speed up that the movement in the GI system so that they will process that food a little quicker. So a few other medications that we see used all the time, pre-hospital, in the clinic, in the home setting, is Tylenol or acetaminophen. It's also abbreviated as APAP. It can be given for fever or mild pain. Antipyretic means for fever or a mild pain reliever. It's available in capsule, liquid, tablets. It can be given rectally as a suppository. Now, if the patient has seizure activity, once again, anything that you would give by mouth, if they are at risk for seizure activity or they are not conscious, we don't try to give it to them. There's not a lot of adverse reactions to Tylenol. Another time we have to be careful about giving Tylenol is with someone who has a liver condition. Tylenol is already kind of rough on the liver, and the maximum dose that you can give is 4 grams a day. But someone with a liver condition, we have to be very, very careful. Or someone that's been drinking alcohol. If someone has been drinking alcohol and they have had too much to drink or more than a couple of drinks, we do not want to give them Tylenol because it can actually it can cause liver failure. So if someone's drinking alcohol, we don't want them to take Tylenol. If they have a liver condition, we don't want them to take Tylenol. Or if they are not awake and alert and can swallow appropriately, we would not want to give Tylenol by mouth. Different things that we use calcium for. So calcium can be used as an antidote for an overdose of calcium channel blockers. to treat magnesium toxicity for hypocalcemia. Calcium can be given for some types of dysrhythmia, because remember back when we talked about other medications that affect, like potassium, and how diuretics can affect the potassium level in the body. We have to remember that if it affects the potassium, it affects the calcium. So it can cause cardiac rhythm issues. And so sometimes we need to give them that calcium back so that it will change that heart rhythm. Also, if someone has low blood pressure, we can give them calcium to increase their blood pressure. Ketorolac, that is an anti-inflammatory. It can be given IM, IV, or PO. It's used as an anti-inflammatory. It inhibits prostaglandin synthesis, which causes that inflammation process to begin. And so what's happening when we give someone, this is Toradol or Ketorolac, we give that for moderate pain. We give it for kidney stones. This is the one thing, if someone has a kidney stone and we can give them that, we can tell it's the difference between maybe a messed up muscle in the back and actual kidney stones. Also, we don't give this to patients who have a GI bleed, because any anti-inflammatory is very hard on the stomach. We also have to be very sparing with how often we allow someone to have Toradol or Ketorolac if they have respiratory issues. It can affect their respiratory response. So someone who has asthma or COPD, we don't prescribe this regularly for. We don't see it prescribed for them regularly. We may give it 1, 2, or 3 doses of it to get inflammation under control, and then they don't get any more of it because of how it affects the respiratory system. Okay, so we have a summary of the whole thing, which I know has been a lot. But pharmacology is a very important thing of what you will be doing as a medical assistant. It's not just because you'll have to administer medications in the clinic. You'll be calling in prescriptions. You'll be putting medications in the medication record. You will be the one running the report to tell if there's any interactions or contraindications in those medications. So you want to be sure that you understand pharmacology. Certain medications discovered in ancient times are still in use. We talked about those, foxglove, digitalis. Those are some things that are still used. In the 70s, we had the Controlled Substance Act, which opened up the window for the DEA, and what kind of opened that area, the DEA. And it started developing scheduled drugs. Schedule 1 drugs, remember, have no medical purpose. Schedule 2 drugs through Schedule 5 they have to be locked up. You have to have significant record keeping. You have to document any wasting of the medication. And you need to be sure that you remember what Schedule 2 through 5 drugs are. Some examples of those, and know that the smaller the number, the more likely it is for them to become addicted to it. All medications in the U.S. are given a chemical name, a generic name, and a brand name. And the Food and Drug Administration, the FDA, are the ones who determine and the process that they have to clear all drugs through the FDA. In the United States, we prefer the two most commonly used, or the most detail about medications are found in the USP, the United States Pharmacopedia, and it's a national formulary for the whole country, or the PDR, the Physician's Desk Reference. Remember that when we store medications, we have to be aware of medications that don't need direct sunlight or ultraviolet light, things that can't be exposed to high temperatures, things that must be refrigerated, things that need to be stored in an area where it's dry. And we also have to be aware that we have to lock up, and all medications have to be under strict supervision, and they have to be locked within a clinic setting. Controlled medications, once again, can't express this enough. They have to be secured. They have to be locked. Usually a double lock system for controlled medications in a clinical setting. You have to have specific record keeping. You have to keep record of not only who you gave it to, how much you gave, why you gave it, when you gave it, time and date, and you also have to keep a record of any that's disposed and who monitored that being disposed. Remember what pharmacodynamics are. We talked about that pretty intensely. Know that medications are developed and researched for an extended period of time before they're actually made available. And that older medications, basically had a broad spectrum of how they affected cells. They affected, if they were going to, like, an example is chemo from the 1990s. Basically, when you took chemo in the 90s and early 2000s, it killed off every rapidly growing cell. That included hair, your stomach lining, all cells that were rapidly growing. Now, as we develop newer medications in the last 10 to 15 years, we've developed medications that target only specific receptors on certain cells. So we're improving the way that we can administer medication so it only affects what it needs to, which will mean we have fewer and fewer side effects. Many factors determine how particular medication will affect a patient, like age, weight, and disease process. Those are three simple things, three very common things that affect how a medication affects another person or affects each person individually. There are side effects and adverse effects, and there are different. Sometimes side effects are not sometimes the side effect of a medication, we actually want that to happen. Side effects are minor issues that are commonly seen with the medication. Adverse effects are undesirable or harmful effects, like an allergic reaction or rash or some other kind of heart damage or kidney damage. Those would be adverse effects. The relationship between the media of an effective dose and the lethal dose. So remember, we talked about median dose, median toxic dose, and medium lethal dose, and the therapeutic index. Be sure that you remember that, because there will be questions, especially on your certification exam, about therapeutic index and the effective dose. Also, repeated exposure to certain medications, especially the controlled medications, and some other medications, can cause the body to build up a tolerance. Therefore, the medication the medication's dose may need to be increased over time, or they may need to be changed to a different medication to prevent that tolerance buildup. Patients that receive multiple medications. So, and this is something you're going to see in the clinic all the time. Patients are on 5, 6, 10, 12 medications. We have to be very mindful of that and make sure that they're not causing adverse reactions or interactions that are not good for the patient, or that there's not any contraindication. Contraindication means do not give them at the same time. That's why we assess their medications. We review their medications every time we see the patient, and we run it through the system, the electronic health record, every time to make sure there's not any interactions or contraindications, because that can be very, very fatal to the patient. And remember that as the body moves the medication throughout the systems, it alters the structure of the medication, and it impacts the bioavailability. The bioavailability is actually, how much the medication is actually available to be used. And so that also is determined by how we give that. Remember what biotransformation is. It's the process that has four possible effects on a medication and how it's absorbed into the body. Know that we are constantly monitoring for medication errors and how to prevent them. And by following the 6 patients' rights, we help prevent medication errors. Also, being mindful of how we store medications, being mindful that we really review the order, and going through all those steps is how we prevent medication errors. Understanding our how to calculate doses. Those are all really important to prevent medication errors. The 6 rights for the patient that we just talked about: the right patient, the right medication, the right dose, the right route, the right time, and the right documentation, and reporting if there is an issue. You want to be sure that you understand the 6 rights, because there will be lots of questions under that, especially for a medical assistant, because you have to be sure you're adhering to those. And then finally, understanding the different groups of medication. So you're learning the top 200 meds and you're learning the classifications. So understanding the classification of medication and what it does. All right, guys, that finishes up pharmacology. So I hope you guys have paid good attention. On Monday, you will get a review. On Wednesday, we'll have a test over this. You will be having practice questions and you will be having dose calculation questions from here on out. Those bell ringers that you've been having, you'll be having those real regularly. I will give you a review for this pharmacology test on Monday, and we'll have the pharmacology test on Wednesday. Okay? All right, and be working on your practice questions for your semester exam. Thanks, everybody. Have a great day.